Good morning, good afternoon, good evening, wherever you are in the world. Thank you for joining us and welcome to today's webinar on COVID-19 and substance use in Canada. Today's webinar will be presented by the Canadian Centre on Substance Use and Addiction, also known as CCSA, and we'll discuss substance use and mental health during COVID-19, the impacts of COVID-19 on the substance use workforce, and the provision of substance use services during the pandemic. I'm Livia Edegger, and I'm the Deputy Director of ISSUP, the International Society of Substance Use Professionals. We are a membership organization with over 20,000 members around the world who work in drug demand reduction. We provide drug demand reduction professionals access to training and credentialing. We provide them with opportunities to build networks, to share knowledge, and learn from each other's work through our website, through our in-person and virtual events, and through the work of our national chapters. I would like to invite you all to join ISSUP if you haven't already, so that you can join our global community of prevention, treatment, and recovery support professionals, and can access the wealth of information that's available on our website. You can apply for membership through our website, issup.net. Membership is for free, and we offer at the moment 4 different levels. Once you're approved as a member, you'll be able to contribute to different sections of our website. The recordings of this webinar and our other webinars are available on our website and also on our YouTube channel. And after this webinar, in the coming days, you will receive a follow-up email with the link to the recording as well as a certificate of attendance. I would like to thank our colleagues from CCSA under the leadership of Rita Notarandrea for presenting their work and their resources today. It's been a pleasure coordinating this webinar with CCSA, and I would like to especially thank Rebecca Jesman, Anna Goodman, and Robert Gabris for joining us today and for presenting their excellent work. Rebecca Jesman is a respected and recognized subject matter expert on drug policy. She provides trusted counsel and expert commentary and presentations at the national and international levels. She has received invitations to share her expertise with the Canadian Parliament, numerous provincial governments, law enforcement, educators, and service providers. And Rebecca will present first. She will be followed by Robert Gabris. He's a research and policy analyst at CCSA. Most recently, Robert has been involved in monitoring the impacts of the COVID-19 pandemic on substance use and mental health. And Robert also works on several projects looking at the health and social impacts of cannabis use. And then Robert will be followed by Anna Goodman. She has been a research and policy analyst at CCSA for over 6 years and has expertise in cannabis harm reduction and qualitative research since spring 2020. Anna has been leading CCSA's work on virtual care and collecting data on the virtual provision of services and support for substance use and concurrent disorders during COVID-19. I would like to encourage you all to, visit CCSA's website and access their resources. And we also have on our website, actually, we regularly feature their resources, and we have listed them as a partner within our knowledge share, and we publish many of their materials, resources, and research. At the end of today's session, we'll have a short Q&A session, so please do send us your questions and your comments through the chat function that is on the GoToWebinar control panel. So thank you again very much for being here with us today, and over to you, Rebecca.
Thank you very much, Livia, for that generous introduction. So thanks to everybody who is joining us today. And let's just make sure I can move the slides here. Excellent. Okay, so I will apologize. Unfortunately, 2 of our scheduled presenters couldn't join us today, but we will certainly be presenting material on their behalf. And if there are any specific questions that require their expertise, we'll be pleased to follow up with you after the webinar via email. So ambitious agenda today. We're going to give you a brief introduction to CCSA, talk a little bit about mental health and substance use during COVID, talk about impacts on the substance use workforce, perceptions and experiences with virtual care, changes to opioid agonist therapy, and then have a quick chat about all of that at the end. So just to start off, for those of us who might not be familiar with CCSA, we are a national non-governmental organization created in Canada in 1988. We work with partners to promote evidence-driven approaches to substance use, to put it very simply. We recognize that although there is excellent knowledge in the field, there are still many gaps between what we know and what we do. So we try to leverage the evidence and apply knowledge mobilization strategies to try to close that gap. We are, whoops, one too many there. So we provide a trusted voice in the field because we're nonpartisan. We work with all partners of all political stripes, and we maintain that all of our messaging is guided by the evidence, which allows us to work with various partners and maintain that reputation for objective neutrality. So I'll apologize, this is a bit of a busy slide, but the key takeaway is that our work is oriented under two North Star outcomes: an accessible and inclusive quality continuum of services and supports, and evidence-informed responses that reduce substance use harms. So it's within that general organizational structure and under those objectives that we have been conducting the work that we're going to share with you here today. So with that introduction, I'm going to turn it over to my colleague, Robert Gabris, to talk about mental health and substance use during COVID-19.
Thank you, Rebecca, and thank you everyone for attending this webinar. It's a pleasure to be presenting for ISSUP. So to give a little bit of background, sorry, I'm just trying to switch slides here and I don't seem to have permission.
It shows that I gave you permission, Rob. I'm not sure how to. Okay. There you go. Does that help?
Now I don't see any slides.
Oh, because you're not the presenter now.
Sorry for the technical glitch, everyone.
Livia, can you give me presentation again? There we go. Okay. Try again, Rob. There, that worked.
Yep, got it. Yep, sorry about that, everybody. So I'm going to be presenting some of our data on our mental health and substance use during COVID-19 survey. And to give you a little bit of background here and why we sort of were motivated to pursue this area of research. So the COVID-19 became a public health emergency in Canada in about mid-March of 2020. And at that time, we saw a little bit of evidence indicating that stress and anxiety was becoming more common among Canadians. And some of our earlier surveys were showing that alcohol and cannabis use have also increased among a proportion of individuals. But at that time, the data were pretty limited and we didn't really know who was being most affected and why. So that's when we began a partnership with the Mental Health Commission of Canada to partner on this, what's now been a year-long bi-monthly survey looking at mental health and substance use over time across several priority populations, two of which I'm going to speak to today. And really what we wanted to do was highlight the intersection or the close relationship between mental health and substance use, something that's been definitely a spotlight during COVID, but something that's been present much before. Sorry, I'm struggling here. Okay, so in terms of methods, we began our data collection back in October of 2020, and we've collected now 7 time points or 7 waves up until September 2021. So we have quite a lot of data, and we have been monitoring a variety of different outcomes over time. But the 2 time points that I'm going to be covering today were time point 4 and 5, which was late spring and early summer, so March and May of 2021. Within the survey, so the survey is pretty extensive. We cover a lot of different indicators spanning mental health and substance use, but we also covered a whole variety of topics around stress, coping, self-care, stigma, access, and barriers to treatment services. But the main barrier or the main indicators that we were exploring throughout the entire study were the ones here on the left. So for mental health, we were looking at depression, anxiety, and suicide ideation, for example. And within the substance use area, we were looking at changes in alcohol and cannabis use, as well as the prevalence of problematic alcohol and cannabis use. Sorry, there's a typo there. So in addition to covering a whole bunch of different topics, we wanted to spotlight a variety of different what we called priority populations that we thought weren't getting a lot of attention in research at the time or in the media or really in the general population. And that included people with past or current mental health and substance use concerns, people with young children, people living alone. And the two priority populations that I'll be talking about in the subsequent slides are people with low income and people who are unemployed or who were laid off because of COVID-19. So these are the four main indicators that we've been tracking over time in terms of mental health. So for comparison, in 2019, so prior to the pandemic, about 67% of Canadians reported very good or excellent mental health. We could see here in the bar on the left that number has, or that percentage has dropped quite significantly to about 40%. Back in 2015 and 2016, we were reporting, or we saw about 2% of people reporting moderately severe to severe depression. And that percentage now has dropped or increased quite a lot to 15%. In terms of anxiety, we're seeing now about a quarter of our participants indicating moderate to severe anxiety. And we don't really have a good pre-pandemic number for that, but in May of 2020, so right when the pandemic started, it was about 20% of individuals who were reporting moderate to severe anxiety. And for suicide ideation, in 2019, prior to the pandemic, 3% of Canadians were reporting thoughts of suicide, and now during the pandemic, it's about 7%. So this again is from March to May of 2021. And these numbers have been pretty much the same since we started tracking. So since October up until September, October 2020 to September 2021, these numbers among the general population have remained pretty much the same. And that's been a little bit surprising to us. But I think what's more concerning than actually these numbers are the next set among low-income individuals. So as we could see here in the yellow bars, regardless of which indicator you look at, individuals with low income are doing much worse during the pandemic than people in the general population. And as an example, whether we look at depression, anxiety, or suicide ideation, these conditions are twice as common among people with low income. And we found pretty much the same sort of percentages for people who are currently unemployed or who have been laid off because of the COVID-19 pandemic. In terms of substance use indicators, same story. So early on in the pandemic, we were seeing that about 1/3 of individuals reported increasing their alcohol use during the pandemic, and that number has been pretty much the same, give or take a few percentage points up until now. So it's still about 1/3 of individuals who are saying they have increased their alcohol use. Similar sort of findings for cannabis, so it's closer to 40%, but that number hasn't really changed since October of 2020. So it's been sort of the same. It's a little bit more interesting with cannabis because we don't know whether people are increasing their cannabis use over time because of specifically the COVID-19 pandemic, or whether that's partly related to the fact that Canada has legalized cannabis use about 2 or 3 years ago now. So that's something we're tracking, and some work that we're doing internally to figure out how much of the variance is related to, or the increase in cannabis use is related to the pandemic specifically, or related to cannabis legalization in particular. In terms of problematic alcohol and cannabis use, so we're seeing about 21% of people screening positive on the alcohol use disorders identification test, so the audit, for problematic or risky alcohol use. And that's also remained pretty much stable over time since we started tracking. Whereas for cannabis, it's been closer to 40% who meet criteria for problematic or cannabis use using the QDIT, so the cannabis use disorder identification test. And we don't really have good pre-pandemic data on problematic use, just because we haven't really come across any national or nationally representative surveys that have used the audit or the QDIT. And again, we could see here, just like the mental health data, people with low income are reporting more substance use concerns. But what's interesting here actually is if we look at the bars on the left side for increased alcohol use and here for increased cannabis use, we see that it's not that much greater of a percentage among low income people. But we do see that problematic alcohol and cannabis use are considerably higher among low-income individuals, and we see the same thing actually for a little bit slightly lower, but for individuals who are unemployed or laid off because of COVID-19. So this is sort of one of my favorite areas, and I kind of say that at every single webinar presentation, but we've been looking at stress since the beginning as well, and social isolation and financial situation have been the top stressors for people pretty much since the onset of the pandemic, and that doesn't seem to be changing. Whereas health of a family member or personal health have seemed to have decreased over time. And what's interesting here is the next point. For low-income individuals, we could see that financial situation is considerably more common, is a more common pandemic stressor among these individuals compared to the general population. And that, of course, isn't exactly surprising, but it is sort of showing how, while the pandemic is obviously stressful for everybody and it is impacting everyone, there are different types of stressors that are affecting certain populations over others. And for our unemployed group or unemployed laid off group, it's similar. So the top stressor again is their current financial situation, and not surprisingly, the second most commonly reported stressor is their employment status. In terms of mental health treatment services, so we're not really showing impressive data here. The percentage of individuals who are accessing treatment isn't very high. In terms of in-person treatment access, it's around 8%, and we're seeing a slightly higher percentage accessing virtual care services. And it is a little bit higher among individuals, who are individuals with low income and those who are unemployed or laid off. And we tried to triangulate these findings to see whether access rates have changed from prior to the pandemic and now, and it's been a little bit difficult, but we have several other variables, and it seems that access to treatment actually hasn't really or notably changed during the pandemic, at least not for mental health services. And a similar story for substance use treatment services. So we're seeing about 2% of people in the general population accessing treatment services for substance use in person, and for virtual, it's slightly higher. Of course, these percentages are lower than for mental health. Substance use services access is generally lower than mental health services, but again, we haven't really seen this increase much since prior to the pandemic. But we do see that individuals who are reporting low income or those who are unemployed are accessing treatment slightly more than individuals in the general population, but whether that actually parallels their need. So as I showed earlier, individuals with low income are a lot more likely to report mental health and substance use concerns, but access rates here don't really seem to be that much higher. So to sum up, oops. Oh, sorry, I actually was speaking to the wrong slide. So for substance use treatment services, we see that the general population is around 2 to 3%, depending on whether it's in person or virtual. For low income and unemployed individuals, that percentage is again slightly higher. Same story as for what I just showed on mental health services. But again, we don't know whether or not this is actually meeting the needs of these individuals. So to sum up, the substance use and mental health impacts of the pandemic are certainly interrelated. And not everyone is being affected equally. So we see that mental health and substance use is considerably worse, for lack of a better word, among low-income individuals and those who are unemployed. And the pandemic stressors differ across different groups of individuals. So what this sort of says, to sort of sum it up, is that we do need targeted interventions to meet the needs of the people that need it the most. And currently, current services are not reaching the majority of individuals who would benefit. So that is it for me. And now it's on to, I believe, Rebecca or Anna. Anna.
No, actually, it's Rebecca. So thank you, Robert. And sorry, just lining up my presentation here. Perfect. All right, so going from the impacts to what our substance use workforce is doing to try to mitigate some of those impacts. So CCSA has been reaching out to our partners over the course of the pandemic, hearing from service providers, from policymakers, and from people with lived living experience. And what we've heard, keep in mind that Canada, like the US, was already being impacted by an overdose crisis, and COVID has only magnified those impacts. As a result of those combined crises, the workforce is really facing a lot of grief, a lot of trauma, a lot of burnout coming into COVID-19. And we know that in the context of COVID-19, particularly during the initial lockdown phase, there were a lot of challenges to service provision. Access to PPE was an issue for substance use providers. In Canada, substance use is generally an unregulated profession, and services did not receive the same access to PPE as other services in the health system. And as a result, could not operate safely and protect their staff and clients. So many had to significantly reduce hours or close altogether. Also, physical distancing requirements meant reduced capacity, so reducing the number of people that could be supported at any one time. And we certainly heard that those services that are closer to the ground were most strongly impacted. So, for example, those providing peer support, those providing outreach because of limitations in mobility and not being able to go into people's homes, et cetera, not being as active in the streets, people sheltering in place, and therefore reducing the number of contacts with service providers, and certainly, again, harm reduction. A lot of concerns, even as basic as if somebody is experiencing an overdose, is it safe to provide CPR to an individual in the context of COVID? And we know that those who are most marginalized in the population were most impacted in terms of distrust of safety in shelters, et cetera, and therefore trying to respond to the really rapidly changing service needs and service context, and of course the added pressure of switching from an in-person to a virtual format, which Anna will speak to momentarily. So to get a better grasp of this work, whoops, sorry. Hopefully going back one, there we go, nope. So some of our colleagues at the Canadian Health Workforce Knowledge Network and the Mental Health Commission of Canada have been conducting a multi-method study that's been funded by the Canadian Institutes of Health Research. So I'm going to share with you, with their permission, some of the results of that work today in terms of focus on the substance use workforce. And I'll note that the mental health data is also available, but I will be focusing on substance use today. So as you can see, there was an increase in both clients presenting for alcohol and clients presenting for cannabis over the course of the pandemic, according to the reports by service providing or respondents. What this means from a policy perspective, of course, is that there's more demand for addressing clients' needs on a workforce that is already taxed and having difficulty meeting demand in the first place. Unfortunately, there are many gaps in service capacity in the specialized services for substance use and mental health in Canada. So we're looking at further exacerbation of these gaps. We also know that those experiencing problematic substance use don't necessarily access the specialized services first. So this also points to the need to make sure that those other access points, for example, primary care and social services, have the knowledge and resources to provide effective support. Sorry, okay, back to the right slide. So in terms of the impacts on the substance use workforce itself, again, over half of the workforce reported decreased capacity. What's interesting is that among the substance use respondents, we did see reporting decrease in capacity. The mental health workforce respondents to the survey didn't report that same decrease. So we looked a little bit more at what the data were telling us, and really seeing that it seems to be more the kind of on the ground and community-based service aspect that was impacted, which generally impacted the substance use more than the mental health workforce more strongly, for many of the reasons that I already discussed in terms of the capacity challenges due to lockdowns and social distancing. We heard from providers that virtual care was a very steep learning curve in terms of picking up their skills, also for client capacity to access the technology that they needed or the digital literacy to use it. We also heard from providers that, like many of us, they're experiencing Zoom burnout, so just finding that kind of stressful. One thing that was interesting, though, was the increase in peer support services. And that happened across both mental health and substance use professions. And one thing that we're looking at, or studies looking at perhaps exploring further, is whether that's been particularly facilitated by virtual care and just the broader audience that can be reached in a virtual format versus how many chairs you can arrange on a particular community center. Oh, I always seem to click one extra. There we go. So in terms of what we heard from the workforce about what is needed to better meet needs in the community, we heard resourcing, of course. We know that the field is largely underfunded and under-resourced. The field is largely unregulated. Peers in particular are often engaged on a volunteer basis. There are a number of certifying bodies, but this is primarily voluntary and without central coordination. The lack of regulation, unfortunately, contributes to a perceived lack of professionalism in the field, and means that those working in the field often don't have access to a professional body to raise concerns or access information. Where there has been some coordination in Canada, so notably in Alberta, where regulation of bed-based facilities has recently been introduced, we saw an increased ability during the pandemic to share information and implement changes in a more timely and coordinated way. The removal of regulatory barriers is interesting, and we expect that speaks to some of the challenges associated with accessing controlled substances in spaces. Although some providers have taken advantage of the opportunity for some of the exemptions that have been expanded during COVID for pharmacy delivery services and increased take-home of opioid substitution mechanisms, many have not, and that means that providers continue to have to see clients in person, sometimes multiple times a day, to witness dosing, for example, and of course, again, in the context of COVID, with reduced movement and trying to prioritize reduced contact, that has been a challenge. And we're certainly hearing from both providers and clients about barriers to accessing harm reduction services, which, in a workforce that's facing a lot of barriers already, can be very demoralizing. So this is just very quick snapshot of some of the impacts that we're seeing on the substance use workforce, what we've heard from the workforce in terms of what is needed. And we're really hoping to work with partners to help fill, again, some of those gaps. And with that, I will close off. Look forward to your questions, but hand over to Anna.
Thank you, Rebecca. I can't see the slides currently, so just give me 2 seconds here. Just make sure. Okay. I'm assuming everyone can see that. If not, please jump in. But I'm going to be presenting today a mixed method. Oh, you can't see them? I don't know how to. I can see them on my screen, but I'm not sure how to bring them up to you guys. So
I'm just going to take away the presenter and resend it back to you. Also, your webcam's off at the moment too.
Oh, okay. All righty.
Yeah, we can see the PowerPoint now.
Okay, and can you see me?
Yes.
Okay, there we are. So yeah, I'm going to be presenting a mixed method study that we initiated back in spring 2020 and just completed this past summer, and we're still waiting on actually releasing the results. So this is a bit of a sneak peek right now, but I'm going to be covering off the perceptions and experiences of both clients and those delivering virtual care during the pandemic. And before I get going, I should note there are 3 very important partners on this work. So the Royal Ottawa Mental Health Centre, Canada Health InfoWay, and the Canadian Psychological Association. So really quickly, this is all going to sound a little bit obvious given how far into the pandemic we've come, and sort of it was already covered off briefly by Rebecca and Rob. But back at the beginning, so this was around March, April 2020, through consultation with partners and talking to people in the field, there was this sort of growing concern that we weren't really knowing how well virtual care was doing for all the folks accessing substance use and care for concurrent disorders, so both mental health and substance use disorders. And this was concerning because we had such a really rapid shift to virtual care due to all the health restrictions. And we already know this population has certain needs. And the last thing we wanted was to kind of leave anyone behind in this shift or sort of reduce the effectiveness of the care that we were providing this population. So we really wanted to capture how the shift to virtual care was going, and whether or not there was anyone who might actually be detrimentally affected from switching their services to virtual care. So our objectives specifically, so looking at the experiences and perceptions of virtual services and supports. So we spoke both with clients accessing virtual care during the pandemic for substance use and concurrent disorders. We also wanted to get some information from sort of the general population to just gauge the temperature in terms of how they felt about virtual care for these reasons, because it was becoming pretty clear as the pandemic went on that this wasn't going anywhere, and if it was effective, you know, it could be something we could scale up to use in the future, sort of post-pandemic. And what would that mean to Canadians if they do need to access that care downstream? We want to look at the barriers of using these services and find out if there's any way to actually improve delivering this care. We formed an advisory committee of experts in this area. So we had people who were already working in the space of virtual care, people working at different provincial and federal levels, and also representation from our living and lived experience community. And we decided we wanted to sort of collect as much data as we could, and that's sort of why we went with this mixed methods approach and tried to keep the definition relatively broad of what we considered virtual care. So we conducted a national online survey of those using virtual services. And we also, like I mentioned, spoke to just sort of general Canadians as well. This was a tricky one because our biggest concern was that a number of people who either don't have internet service or who aren't comfortable using technology or don't have access to cell phones, all those sort of different barriers, those were sort of the groups we were the most concerned about in terms of leaving behind with virtual care. So it put us in a bit of conundrum because we couldn't access them to actually collect this data because we weren't able to do in-person data collection. So to sort of supplement that group, we thought it might be useful to actually do qualitative interviews with the practitioners delivering virtual care. So actually hear from the practitioners how these particular populations were doing in terms of accessing services. And when I say virtual services and supports, I'm talking about any education, access to care or treatment provided through technology. So we're thinking websites, apps, over the phone, virtual, sort of any way that you could get some sort of education or care related to substance use and concurrent disorders that wasn't in person. So we really didn't want to leave out kind of these alternatives to, Zoom or phone calls, which were in the forms of websites and apps. So first I'll present some data from the group who were actually using virtual care during the pandemic. So we had just over 300 respondents that answered about this. Some of them had been using care before the pandemic. Some of them actually initiated virtual care because it became so prevalent during the pandemic. It actually increased their sort of visibility or their understanding of this care. And overall, we saw a pretty good satisfaction rate, maybe not as high as we were hoping for. So about 2/3 said that they would agree that they were satisfied with the virtual services they were receiving. And in terms of some of the most popular benefits as to the good things about virtual care were the saving of time. So obviously accessing services virtually, you're not traveling, you can sort of work around your schedule a little bit easier than when you have to go to a location. And the fact that it actually prevents the spread of COVID-19. So that was sort of the most popular reason as to why virtual services are a benefit to the population. And we found a lot of interesting sort of demographic differences. There's a lot of data, and I won't get into all of it right now, but I just highlighted some gender differences here for you. So it was interesting that women sort of showed less satisfaction with virtual care. So they actually reported they wanted to return to in-person services when the pandemic ended, and they actually wanted that sort of face-to-face interaction. Whereas men were a little more comfortable doing their care online. So this was sort of a more positive thing for them. And we provided participants a list of sort of the different ways that they could access care after the pandemic. They could pick more than one, but the most popular selection was in-person and telephone. So some of the biggest barriers to virtual care reported by those who were actually using the care at that time was cost. So we asked them, is the actual cost of these private services? So in Canada, depending on whether you have private insurance or not, some services would be actually paid out of pocket. So for example, a psychological session could be about $200 per session. You could need up to 10 sessions. So that can be a significant cost depending on sort of your situation financially. And lack of a private space was a big one. So when you're considering actually using virtual care, you live in a house with other people. Maybe you have a partner who's home and you don't want them to hear what you're saying, or maybe you have your parents around and you don't want them to know that you're using substances, or all of these different reasons why we would want to access this care privately. When you're doing it at your house, you can't actually necessarily find a private space. And there was actually some respondents that said they would go to a friend's house or they would do their services in a car, but the overwhelming majority was accessing care physically in their home. And then finally, the third most popular barrier to virtual care, in the opinion of the participants, was relationship building. So that means specifically, when you're using a virtual platform, do you feel you can develop that rapport and that trust with the healthcare provider delivering the care, or is that going to be a barrier for you? So that was a popular one. And then going back to some of those demographic differences I mentioned, age was a big one. So it was interesting to look at the barriers based on, where you're at in your life. People aged 34 to 54 were most likely to lack privacy. Some of the youth, so I think we went as low as 18 to 33 or 18 to 25, I can't remember. They had different issues around the office hours of the practitioners, or also in terms of finding like a quiet and safe space. Whereas the older age category, so 55 and up, they were more likely to have a private space, they were more likely to have time, but they were a little more apprehensive about the virtual delivery of services. So they were most likely to feel they couldn't have that rapport with their healthcare provider virtually. And then we asked these respondents how they would feel about our government investing in these services over time. And a really large majority, almost 70%, do feel that the government should make this a priority in terms of investing in this care. And then, as I mentioned, we also got a good chunk of the general public to respond to some of these questions. It was a bit of a different survey given they weren't actually accessing these services. But we did say, would you be comfortable in the future? And 3/4 felt they would be comfortable meeting a nurse or doing an individual appointment virtually in the future, specifically for substance use and concurrent disorder care. About a third only a third thought that virtual services would be as effective as in-person services. So they were apprehensive that getting care this way would be as effective as if they were going into an office or speaking with someone in person. Something we found interesting when we were comparing the people who were actually using care to those who were just general public. The general public were much more likely to be concerned around their privacy and security of their health data. So again, using a computer, using your phone, are you opening yourself up to your data being overheard or stolen or shared or whatever it might be? That concern was more common among the general public, whereas those who are already using care, we could maybe assume they've kind of been using it, they realize it is safe and they're comfortable with it. And then 2/3 of the general public felt this should be a government investment as well. So as I mentioned, we also did some qualitative interviews with practitioners delivering virtual care. So we had about 14 respondents. We had hoped for closer to 30, but given that they were very overburdened during this time, we wanted to let them sort of pick if they wanted to participate, and that this was the number we got back. So we spoke with counselors, psychologists, social workers, educators, harm reduction providers, and all of them had been doing their services in person before the pandemic, but obviously they used telephone and email in some capacity, but a lot of them didn't have sort of a plan or an infrastructure put in place pre-pandemic that would facilitate sort of smooth transition to virtual care. So thinking of logistical things like consent to provide information online, the actual equipment needed both for the practitioner and the client to access virtual care. There wasn't necessarily these things put in place when the pandemic began. So because of COVID, a lot of them did have to kind of act fast and get their services online and some onto the phones. Interestingly, a lot of them kept going into the office regardless of sort of the risk that it put them at, which I think was really commendable. So they still went into the office even if the PPE wasn't readily available, and they knew that if they didn't go into the office, those particular clients would have zero access to care, whether it was due to their technological abilities or their access to a phone or computer. And this was very concerning given that those sort of at-risk populations most need these services. So when we asked about how the experience went in terms of virtual care, generally there was a steep learning curve in terms of adopting the technology and the sort of different paperwork for the practitioners and the clients. It went really well for those clients that already had that infrastructure in their homes and in their lives. So thinking of people who use a computer every day and have a cell phone, it was really easy for them to jump on board, but there was a lot of concern around the more vulnerable populations that were being left out. So people that are without homes, people in more rural communities, people with lower socioeconomic statuses or certain abilities may not be able to use these services in the same way. But there was some benefits. So there was a greater connection to people. So in Canada, a lot of our services are provided in those more metropolitan areas. And then we have a lot of rural space where people might live hours away from a city center. And those folks would have to drive in to get care. And with virtual care, they were able to actually get the care over the phone or via computer. And this was obviously made things a little more flexible. Another interesting thing that the practitioners mentioned with virtual care was their ability to actually see the homes of the people they were providing care to. So before, you'd have people come into the office, you couldn't really assess how maybe their care was going on in their house. But if you have a video into the home, you could see if there's cleanliness, to see if there's care being taken in the home. And that was just sort of an added data point for these practitioners to really get a good sense of how their client was doing. In terms of drawbacks, as I mentioned, not everyone has access to internet and technology, especially in more rural areas where internet might be weak or not accessible. And accountability issues. So these were interesting. So in terms of actually accessing care via a video or a phone, the practitioners felt that clients were more comfortable with no-shows. So you have that accountability of someone waiting in an office for you, but if they're just calling you on the phone, you don't feel like going that day, it's a little bit easier to just sort of opt out. They also mentioned that some people were actually using substances during the sessions within the home or over the phone. Maybe they would turn their camera off, or they'd get up and leave the room. So there was sort of that less controlled space when they were delivering care as they would have received in an office. And finally, sort of in line with what we heard from the quantitative survey, practitioners really don't feel that virtual care is going to replace in-person care, and I'll talk about that in terms of the implications for next steps. So a lot of really important things came out of both the quantitative and the qualitative data, and I think there's a lot of work that could be done in terms of educating the general public around the effectiveness of virtual care. So there's this perception it isn't as effective as in-person services, and we have a lot of good data showing that it can be, and there can be a lot of benefits to accessing care virtually. So sort of getting that information out to the public, letting them know we can secure their private data, we can secure some safety for them, might be really helpful in terms of rolling out more virtual care. Increasing that comfort with technology for the practitioners, so really building in training and logistical support into the roles of these healthcare providers that might not have been previously there, sort of reevaluating what their roles are in the office and ensuring they have the capacity on taking on the virtual piece as well is going to require some restructuring. And then ensuring we're adapting our provisions of services based on these different geographic locations, based on people's age, based on gender. It's really clear that we're going to have to continue providing both in-person and virtual services if we want to make sure that different types of people can access the care that is most beneficial to them. And finally, increasing internet. So this might not be necessarily an issue in all countries, but in Canada and our more large rural areas, you're not necessarily getting the same internet speed and internet connection. And we also want to increase access to safe spaces. So whether it's in a community center or a doctor's office that's close to home, is there some sort of way to provide an internet connection and a quiet room for someone to come in, take their virtual session, and then go home if that's something that they want. So that was, I believe, it. So I will send it back to Rebecca.
Great, thank you very much, Anna. So I'm very pleased to share with you some research that we've been conducting with partners at the Royal Ottawa Mental Health Centre and the Women's College Hospital on Ontario's new opioid agonist therapy prescribing guidelines. Just make sure I can change the slide here. There we go, perfect. All right, so, oops, just lost it, there we go. So the study was conducted, as I mentioned, in partnership with the other organizations, basically recognizing that opioid agonist therapy is the gold standard of care for the treatment of opioid use disorder, but that also typical OAT, I'm going to call it for short, follows a rigid dosage and monitoring schedule, including frequent office visits, as I mentioned earlier, and urine tests, et cetera, to monitor for signs of substance use, as well as supervised ingestion of the medication at a pharmacy. These provided challenges in the context of COVID. So the province of Ontario, or in Ontario rather, a group of Ontario clinicians got together to support physical distancing while maintaining continuity of care with guidelines that suggest reducing the frequency of clinic visits, expanding virtual care, reducing the frequency of urine drug tests, and increasing take-home doses or carries, including for individuals who wouldn't usually have met the criteria. These guidelines were rapidly and widely disseminated through networks across the province. So the purpose of the current study was to assess how care delivery has been affected by the guidelines from both client and prescriber perspectives. So the methods used, we surveyed clients and prescribers across Ontario. You can see a little bit about the characteristics of the study sample on the slide. We recruited clients through social media posters and flyers in OAT clinics and pharmacies, and we recruited prescribers via social media posts to listservs and just good old snowball sampling. So in terms of what the findings told us, the vast majority of prescribers had read the interim guidelines, and of those who reported reading them, almost all, so 99%, reported making changes in their prescribing of carries. Most providers reported prescribing carries to patients who were not receiving carries prior to the pandemic, in addition to increasing the number of carries for patients who are already receiving some. And 58% of clients reported receiving additional carries during the pandemic. Most clients and prescribers responded positively to the changes in care. From the client's perspective, 59% reported that they could be more open with their prescriber, and 74% felt that the changes helped to protect them from COVID. 70% of the prescribers reported the ability to offer more take-home doses improved the relationship with their clients. Most clients and prescribers were satisfied with virtual care, but as Anna noted, there's still room for improvement. 66% of clients felt that the virtual care improved access to OAT, and 64% reported it improved access to the prescriber. And of the prescribers, 65% felt satisfied, but also many noted that they felt unable to assess clients virtually as well as they could in person. In terms of client-reported benefits and challenges related to the additional doses, just note here that of the clients who received additional carries, about 44% noted that it saved them time, and 33% noted that it also saved them money. However, there were also some challenges. 23% reported lost or misplaced doses. 19% indicated that at least some doses had been stolen, and 65% reported that they had shared some of the carries. However, we did see that the additional carries were not associated with self-reported adverse health outcomes. That includes the fact that clients with carries were no more likely to report opioid overdose, emergency department visits, or hospitalization compared to clients who did not receive additional carries. So in terms of the implications, it should be noted that there are some limitations to the study. It was an online survey, so it may not have reached some of the priority populations within opioid agonist treatment clients. Particularly, we saw this reflected in the relatively low number of clients who indicated the use of fentanyl, where we know how widespread fentanyl is, in fact, in the community today. Client and provider groups weren't matched, which may explain some of the discrepancies between client and provider reports about changes in care. And it should be noted that data were collected in August and September 2020, which was beyond the peak pandemic measures. So some of the new practices might have started to scale back a bit. The research explored client and provider experiences with the new approaches, with the objective of informing ongoing policy and practice development. So some of the key take-home messages that we're pulling from the study so far are that most clients and prescribers responded positively to the changes in care delivery. Our findings suggest that prescribers and policymakers should continue to actively explore ways to reduce barriers to OAT care beyond the pandemic, including ensuring access to virtual care, revising practices that rely only on high frequency and in-person visits and urine drug screens, and reconsidering the criteria that stipulate when clients are eligible for take-home doses. In terms of what we're looking at in the future, moved to the future a little bit too quickly there. We recognize that the challenge of OAT provision during the pandemic is not unique to Ontario. Other jurisdictions were also required to innovate and develop alternatives to prescribing. In BC, for example, registered nurses and registered psychiatric nurses are now being trained to prescribe OAT as part of the province's work to combat the overdose crisis. There's a need to ensure ongoing planning of robust policy that can support the long-term sustainability of the guidelines that allow for alternative methods of delivering care. Practitioners require support, training, and mechanisms for updated knowledge sharing around the provision of alternative models of care for delivery for OAT. So that involves working with the colleges. We need greater access and awareness for clients in order to expand uptake and reduce disruptions in care. And that includes investment in digital health programs and access points for clients at the community level as well. And improving access to other harm reduction services and strategies to ensure a comprehensive continuum of care, and that includes psychosocial supports and community and temporary housing. So with that, I think we can turn over to questions and comments. And of course, as was previously noted, for more information on anything we've presented today, you can go to our website at ccsa.ca. I would be remiss to not point out that, whoops, I think I lost control. That's okay. Hopefully we can get back to that other slide later.
Great, thank you very much, Rebecca. And we can share if possible. I'm happy to give you control again. So you can share that slide again.
Okay. We can move on to the questions. I'll just note that CCSA is coordinating our Issues of Substance biannual conference next November. If you'd like to learn more about what's happening in substance use in Canada, I highly recommend you check out. If you Google Issues of Substance, you will find it quickly.
Excellent, perfect. And we're also happy, as I mentioned earlier, we will send out a follow-up email. So if you could just send that link to us, we can actually include it in the follow-up email that will go out tomorrow.
Perfect.
Great, excellent. Thank you all very much for your presentations. A lot of useful information. Oh, great. I think we've got the slide up there. Excellent. A lot of information. I'm just going through some of the questions. Thank you all very much for those who have sent them in. I had one when Anna, when you were presenting, there were, especially with you mentioned the increasing access to internet, and that virtual care can indeed be problematic, especially in rural areas. And so I think you mentioned that, yes, increasing access, creating safe places. Is there anything else that, in order to make sure that people that live in rural areas around the world that could get access to those to virtual care, and if not, what other services would you look at providing to them?
I think there's sort of a lot of work that still needs to be done in terms of, targeting specific populations. So when we talk about sort of rural and remote communities, that could be Indigenous communities that are in a very different circumstance than someone that might just not live close to a city center. So they have particular services that will be more beneficial to them, more effective to them, based on kind of that population specifically. And in terms of the more rural access, it sort of depends, right? If they do have the finances to maybe get into a vehicle and get into the city center, then that would be helpful for them. But if they don't, then I think we're really going to be looking to the government and provincial or territorial areas to find ways of either supplementing internet more broadly or providing access to technology like phones or computers through grants or subsidies. So again, I think it just sort of goes back to how every client has their own different needs based on socioeconomic status, based on their location, and it's sort of up to us to provide that slew of options to tailor by client.
Great, thank you. There is a question, I think this one came up when you were presenting, Robert, but it links very much to Rebecca's final presentation. And this was when you presented the survey, Robert, somebody asked if you also looked at overdose death in the survey.
No, we did not. So we did, early on in the pandemic, we were tracking the use of prescription drugs, including opioids. We just didn't have a large enough sample to be able to report on that to at least confidently report, but Health Canada does, and Statistics Canada, I believe, do track that, and it's easily available on the Health Canada website. Maybe Rebecca could speak a little bit more to that.
I think, Rebecca,
there's a lot of statistics available on the Health Canada and the Public Health Agency of Canada websites. Some provinces are releasing their own data as well. In particular, BC, Alberta, and Ontario, I believe, has also released some stats. We've seen a huge increase in overdose deaths, unfortunately, over the course of the pandemic, seeing levels that we have not seen before. And, you know, the combination of increased isolation, meaning less people around to intervene in case of overdose, as well as the increased toxicity of the drug supply, have really combined to have devastating effects.
thank you. There was another one coming back to virtual care. What ethical guidelines should be put into consideration when using virtual care? It's a very broad question.
I think that's sort of another area that we're probably going to need a bit more work. I know that from some of the practitioners we spoke with, a lot of them did have to redo all their confidentiality agreements, all the paperwork that clients generally sign when they're, you know, signing up for these services had to be amended and had to be changed, and that took quite a lot of time. So ideally what we would be able to do is sort of go back to these practitioners that had successfully kind of switched to virtual care and kind of get some best practices going and put these policies in place so that there can be sort of a smooth transition when we are switching to virtual care. But yeah, unfortunately I can't speak to any specific details exactly when delivering care that way.
Good, thank you. Then there's another one. Let me see. I'll ask this one first. There's a couple of more coming in. We have one question asking, do practitioners get to involve family members or significant others whenever possible in providing remote care to clients with mental health and substance use disorders at home? So this is about involving family members.
Yeah, in terms of the data that we collected, I don't specifically remember anyone mentioning also speaking with family members, but that has been identified by our partners as a key group that we should maybe follow up with, especially in regards to virtual care, given that we do know they're an important component of providing these services, and sort of, is there going to be a way to both involve them virtually and the client, and how is that going to look? I would be really interested to see if that's being done successfully anywhere.
Good, sounds good. The next one is about doctors and practitioners, and if you have any data on, if in any of the surveys, if you looked at kind of, I guess it says here, fears, anxiety, you know, that doctors or practitioners had during the pandemic. So I guess affecting their mental health.
Absolutely. The larger study that I spoke to does include, the sample includes practitioners of all stripes in terms of provision of mental health and substance use services. So when the full study results are available, the individual who's interested will be able to take a look at the data according to type of practitioner. And there were definitely some interesting patterns seen in terms of the different impacts that COVID has had on the different profession types. So we'll have that information available on our website, and the individual is welcome to reach out to me, and I can make sure that we get a copy emailed out as soon as it's ready.
Great, excellent, thanks very much. It's much appreciated. Let me just see if there's anything else. Okay, were there any, this is again going back to virtual care, were there any cases so I guess looking at youth and especially minors, so if actually if you have data on that minors were part of, you know, and actually were trying to access virtual care due to mental health issues during the pandemic.
Yeah, so we went back and forth at the beginning when scoping out the survey on whether or not to include minors. Ideally, we would have, but we just felt it was just too large of an undertaking, and we wanted to actually survey them separately to see sort of how it's going. We have some really good examples in I think, British Columbia, where they have put in more virtual services for youth, and it is very successful. It is going well, and just sort of based on sort of the demographic differences we saw in our survey, I think it really points to the fact that certain age groups are going to respond better to certain types of services. So this would be something to explore specifically for youth. We have seen research showing that youth respond well to certain types of virtual services, especially those that are a little more social media based as opposed to maybe just Zoom calls. You know, it really points to the need for thinking of some creative ways of providing services to youth who might feel more comfortable just maybe texting live with a practitioner or going to a website and having like peer support that way. So certainly these examples are starting to come out, and I think as years go on, we're going to see this happening more.
If I could just add a note to that, one thing that we also heard, though, is specifically for some of the lower socioeconomic status and more marginalized youth, access to data plans was a challenge. So particularly during the lockdowns where you couldn't go to, get free library access, for example, accessing the data in order to use virtual care was problematic.
Great, good. I think, I think that's it. I don't see, we're getting a lot of thank you notes and congratulations. So thank you very much for presenting the research and the results of the surveys, and we'll look forward to getting, the final publications and being able to then share those with our members. Again, as I said at the beginning, for those of our members who would like to rewatch the webinar, we will send out the link tomorrow, and then we'll also send out again, because I see also that people are asking again for the website, and we will also send that link with all of the information. And so again, thank you very much to Rebecca, Anna, and Robert for presenting today and joining us on today's call. And we will share all of the information with all of our members, and again, connect you if, in the future, once the publications will be online. Thank you all very much, and stay healthy and take care.
Thank you. Take care.
Take care.